وعشان ان شاء الله باذن الله يتنوا الموضوع مستمر اجيال ورا اجيال لما تبقى النقابه بتدعمه يعني ان شاء الله باذن الله. بسم الله الرحمن الرحيم، الحمد لله رب العالمين، والصلاه والسلام على سيدنا محمد اشرف خلق الله اجمعين. سبحانك ربنا هديتنا لهذا وما كنا لنهتدي لولا ان هدانا الله. الحمد لله رب العالمين، اللهم لا سهل الا ما جعلته سهلا. يشرفني ويسعدني اليوم ان اقدم استاذ الدكتور عادل احمد حسين، ذلك العلامه العالم المثقف المتدين الذي يبثنا كل يوم كل انواع الثقافه، واعتقد انه بالنسبه لي على الاقل هو يعني حد ايقونه في العلم والاخلاق والدين والتصرفات الحسنه الجميله والمتبسم في وجوهنا جميعا، وهذه صفات جميله الانسان المسلم العالم العلامه. فربنا يزيد حضرتك من فضله في خيري الدنيا والآخرة إن شاء الله، ويجعل وقفتك معانا والسبورت اللي انت عملته للمابيك المنوفية أناثيزيا بين اند ICU كلاب في ميزان حسناتك إلى يوم الدين كجبل أحد إن شاء الله يا رب، اللهم آمين. ويعني أنا يعني إن شاء الله أظن في كل الخير، وإن شاء الله ربنا يجعلك أحسن مما أظن مليون مرة، إن أنت إن شاء الله يعني ستعاود لنا اللقاءات والزيارات وهتمنحنا وتنفحنا من علمك العظيم. وشكرا لحضرتك. ودكتور شريف والدكتور ثروت هم اللي يقدروا الألماظ ويقدروا حضرتك أكثر مني 100,000 مرة. تفضلوا يا فندم.
الله يخليك. السلام عليكم everybody.
السلام
عليكم السلام ورحمة الله وبركاته.
Thank you, Professor Safa, for your kind invitation. I'm really overwhelmed and delighted today to be among you, and was one of my beloved persons in my life is my professor, Dr. Adel. So today it's going to be a special day, I believe, because we have elegant speaker, eminent speaker, is Professor Dr. Adel. And I cannot say anything after you have said, Dr. Safa, about Dr. Adel. He deserves more and more and more than this. And we have a very fascinating topic as well. Less is more in ICU. It's a very interesting topic, and it's also a very debatable topic in the intensive care field. Who's interested in the field of intensive care, he can know that less is more in different topics and what is the evidence behind. We have less is more in ER deaths, for example, like less tidal volume can save lives and less pressure save lives, but high pressures or more tidal volume can kill the patients and increase the mortality. This is one of the examples. Other example, more fluids associated with poor outcome, less fluids, although it is a big area of debate, and you guys may attend the last critical care review meetings this month, and the debate around restrictive versus liberal fluid strategy in septic patients. And we have, of course, some trials about that. It's been discussed in CCR 22. We have less is more in many areas in the ICU, and Dr. Adel is gonna highlight all these issues tonight. And I'm pretty sure we will have a lot of knowledge today, and it's gonna be a thorough review of the critical care tonight with Dr. Adel. I know Dr. Adel ages ago. He's an eminent professor, critical care professor, former professor of critical care, Qasr Aini, Cairo University, and he was the head and the director of critical care department at King Abdullah Medical City, Mecca, and I honored to work under his supervision for 4 years over there. And Dr. Adel is a consultant critical care currently in King Abdullah Medical City, Mecca. He's our speaker today, and Dr. Sharif, if you would like to add anything, but just I would like to highlight 2 points, please, guys. Pay attention to Dr. Adel to get the best of the topic tonight. And you can drop down any questions in the chat box, and we'll pass these questions over to Dr. Adel And please, we have a link for feedback at the end of the session. If you can do a favor for us, it is going to take just 2 minutes, and fill in the feedback, please, and send it back to us. Thank you. Dr. Sharif.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim.
عليكم السلام ورحمة الله وبركاته.
Nothing to be added after you, Dr. ثروت and Dr. صفاء. وانا مش هضيع وقت كتير، احنا حابين نسمع الدكتور عادل. اتفضل استاذنا دكتور عادل.
طيب، بسم الله الرحمن الرحيم. طيب، بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف خلق الله المرسلين سيدنا محمد صلى الله عليه وآله وصحبه وسلم تسليما كثيرا. بداية أسأل الله تبارك وتعالى أن يعلمنا ما ينفعنا، وأن ينفعنا بما علمنا، وأن يستخدمنا لنفع البلاد والعباد، اللهم آمين. كما أسأله سبحانه وتعالى أن يجعل هذا اللقاء في موازين حسنات أستاذتنا الدكتورة صفاء هلال وزملاء دكتور ثروت عيسى ودكتور شريف. السلام عليكم جميعا، حياكم الله وبياكم ومساكم الله بالخيرات. third point أو النقطة الثالثة، طالما اتكلمت بالعربي في البداية بعد الحمد والصلاة على النبي صلى الله عليه وسلم، لابد أن يعني أدعو بدعاء رب اغفر لي ما لا يعلمون واجعلني خيرا مما يظنون ولا تؤاخذني بما يقولون. First of all, I have to express my great happiness and appreciation for this kind invitation from Professor Dr. Safa Hilal, who was enthusiastic to involve me in the Anaesthesia and ICU club, and it's my great pleasure to be among you tonight. This is I have to address it at the beginning. Second, I have to thank Dr. Tharwat for his introduction. My dictionary cannot express how Dr. Tharwat is for me, and I'm really grateful for his introduction, and I think I did not deserve or I don't deserve what he said about me, because at the end we are really friends and colleagues. Also, I am thankful for Dr. Sharif for attending with us, and it's my honor and pleasure to be a moderator for my session tonight. أسأل الله تبارك وتعالى أن يتقبل هذا اللقاء وهذا العمل في موازين الحسنات. Dr. Sharif and Dr. Tharwat, is my slide shared? And my voice is clear before proceeding to the core of my topic?
That's very clear, Dr.
Okay. So let's go to the title. As Dr. Tharwat, I think he gave a summary already for my topic with his intro. So the topic, I think, is not away from your ears, that less is more, even in the ICU settings. I have nothing to disclose tonight, and I hope this picture express clearly the idea behind my topic, or it can summarize the idea behind my topic tonight. I know Dr. Tharwat already he gave a hint, or I can say he gave a sum up for my talk tonight. And this photo can add to his intro that sometimes less is more, not only in the medicine, but in your daily life and in your daily practice. So the motto or the paradigm of less is more is very clear on your daily practice, even if you are not in the medical field. And sometimes the motto or this paradigm of less is more is a great source of happiness in your life and add to the value. So to highlight or to give an outline of the objectives of my talk tonight, first I will highlight why less is more is a new paradigm in ICU settings, and honestly is not a new paradigm. I will explain more in the next or the upcoming slides. It's not something new, but when I see new, I'm telling it's a very dynamic from the base, then ups and down, wax and waning, but at the end, as Dr. Tharwat mentioned in the intro, that there is an evidence-based behind the less is more paradigm. Next, how can less be more? How can less add to the value? How can less add to the quality? How can less add to a better outcome? Then I will talk about the famous campaign, or the Choosing Wisely campaign, and I know that most of you are aware, especially the ICU practitioners are aware about the Choosing Wisely campaign. Then there are times when more is more, and I think this topic is totally linked to my topic tonight, but because of the time frame, this is can be a part 2 or another talk or another presentation or another meeting when more is more. So excuse me, because of this objective, just I would like to highlight it here in the objectives, but just to mention to you that I'm not always with less is more, because sometimes more is more, and I can explain it inshallah ta'ala if there is كان في العمر بقية inshallah ta'ala when more is more. Then how can we implement the Choosing Wisely campaign items, either 5 or 10 or the whole 10 in your ICU, either on local settings, even on private settings, on governmental settings, or national settings. So this is the objectives, and I hope inshallah ta'ala within the upcoming slides and the remaining time that I can give you something, or I can highlight something can help you to revisit our practice in the ICU once more, to see that what we are doing less and getting more, or we are doing more and we are getting less, or we are doing more and we getting more. So those are the 3 R's. Are we are doing less and getting more, or we are doing more and getting less, or we are doing more and getting more. And sometimes you are doing less and getting less, of course. Okay. So from the field of administration, not in the medicine only, we have something called the value equation. What's the value equation? Value, it means that the quality of your work, whatever medicine or non-medical, divided by the cost. So there is a direct relationship between the quality and the value, and the inverse relationship between the cost and the value. So how can we explain this? The value is usually or more than a buzzword in medicine. It's the way of medicine work. This is the value, and this is directly linked to critical care settings. Understanding just what it means and how to achieve the value could make or break the ICU management and other specialties, not only the ICU. When you understand what does it mean, the value, and how you achieve in comparison or putting in your mind the quality and cost, so this can make a difference or a breakthrough in your ICU settings or critical critical agents. And this is the value in the healthcare settings, how value-driven healthcare relationship between the cost and the quality. So if I'm talking about value, cost, and quality, so you should give me an example. So to make it more simpler, more understandable. And I agree with you. You have to give me an example so I can understand well what you mean by this. So there is a common practice in the ICU or in medicine sometimes, even in ER settings, while watch and see or wait and see. While this practice, waiting or wait and see, has waiting, waste related to the liberation from ICU or discharge from ICU. So in general, the biggest waste in medicine, in my opinion, is waiting at any specialty. And proactive scheduled weaning will reduce the waiting. This is also one common practice, that when you act proactively, you will not wait. You will proactive weaning protocol, your active sedation, proactive sedation protocol. You're acting proactively. So you have electrolyte protocol. So you have a proactive scheduled protocols or weaning protocols, for example, and this will reduce the time and the waiting and the waste, and of course the cost, and of course the length of a stay. So reducing waiting in ICU, of course, it will be directly reflected on the value, and of course it will increase the value. How? By improving the quality, number one, and decreasing the waste. How it will decrease the waste? By decreasing the unnecessary or nullifying the unnecessary costs. For example, most of the literatures and the studies and randomized controlled trials dating years ago have failed to demonstrate that more invasive hemodynamic monitoring in ICU using the Swan-Ganz or the pulmonary artery catheter is beneficial for ICU patients. I'm not generalizing this. Sometimes we need the Swan-Ganz, but is not more the routine practice for invasive hemodynamic monitoring, and this was proved. So this is unnecessary cost, and this will decrease the waste. About another example about the antimicrobial stewardship. I know all of you are aware about the role of the pivotal role of the ASP and value-based critical care. For example, just to make my introduction here is clear, that the appropriate antimicrobial prescription or the appropriate antimicrobial stewardship that include the optimal or the appropriate antibiotic selection, the appropriate dose, and the appropriate duration, as well as the control of the restricted antibiotic use. This, of course, it will decrease or slow or even prevent the emergence of resistance among the bugs or the microorganisms. And I know most of us are suffering now or facing the challenge of the MDROs or the XDROs or the BDROs, multi-drug resistant organisms, extensive drug resistance organisms, or banned drug resistance organism. And I think no ICU worldwide is immune from those MDROs or XDROs or BDROs. In Egypt or internationally, you can imagine how much the burden of this challenge. So let's go for the paradigm of tonight. Less is more paradigm. The last decade in the critical care settings and the medicine has witnessed a gush or slew of studies that challenged the conventional wisdom, and it led to gentler, less invasive approach, mainly in critically ill patients. And we know that the trend is going, as much as you are non-invasive, reaching the goal without jeopardizing the care, it will be reflected in the outcome and the cost and the value. And this is the idea behind the appearance of the paradigm, which is less is more. I know all of us as intensivists, we have goals. Every day you are going to the ICU, doing the round, or even during your on call. Your goal is mainly supportive, and you're allowing the body to heal itself. This is very important. Second, you have to do no harm or limiting the harm we cause usually with our arsenal of diagnostic and therapeutic weapons. We are facing every day when you manage critically ill patients, and this is a motto be when you are managing him or her in the ER or in the floor or in the ICU until he comes to your ICU. You have to reach a quick diagnosis because the patient at the end is critically ill. So you have a battery or arsenal of therapeutic intervention. You are throwing most of them, but unless you have some wisdom to choose what the appropriate diagnostic tool and the appropriate intervention to do, this is, of course, will be reflected in the value and the outcome, and of course, the cost. The current view in the ICU settings that all of us, we are aware about it, and we are telling to even to our juniors that the patient is very sick in the ICU. This is why he is in the ICU. And being in the ICU, he is very sick and he needs a very intensive treatment. So this is the translation of very sick. Very sick, it means that he needs a very intensive treatment. And more intensive treatment may promote the chances of unwanted adverse effects and iatrogenic damage. When you do more, sometimes it will be associated with unwanted adverse effects and iatrogenic damage, and you did not leave the chance sometimes for the body to heal by itself. The critically ill patients probably benefit from some cautious approach or some conservative approach or some less invasive approach. And all of us are feeling this sometimes when you are be less invasive or you are less aggressive. Of course, it depends about the circumstances and the case scenario and the individual patients. But remember that critically ill patients may benefit from more cautious approach or some less when you are doing. And less intensive treatment is associated with better outcome in critical ill patient. This is what the RCTs say to us, and I will show you later the evidence-based, either randomized control trial, cohort studies, observational studies, guidelines that telling us sometimes less is more. And less is more paradigm might not only benefit the critically ill patients, but also it has an impact on the ever-increasing ICU-related cost outcome. So we have to, or we should, reappraise the patient management as well as the trial design when you are doing the research in ICU, while bearing in your mind that less is more paradigm. You can imagine about the overuse, not only in the ICU, but in medicine, of course, either in high-income countries or HICs, or even on the med or low. The overuse is very real, underappreciated patient safety issue. And you can imagine the estimated overuse, which is really underappreciated in the US, for example. So an estimated 1/3 of the care delivered in the US considered as wasteful. You can imagine this 1/3, 30% of the care delivered. This is in the United States. It's ranked as high HICs or high income country, that 1/3 of the care delivered in the US is wasteful. And this is having an impact or a source from physical harm, emotional harm, and of course, financial harm. And sorry, the COVID-19 pandemic was a real example for the financial harm that we face it over almost 2 years. As evidence increases about the harms gained from healthcare overuse and wasted care, the physicians have a professional obligation. This is what we call it, professional obligation, to reduce these events, both individual patient level or on both the individual patient level and across the whole healthcare systems. The overuse may need to be considered equal to the adverse events and should be reviewed in the same context. You should address this on local, national, and international, that the overuse for the intervention, for the diagnostic tools, for the treatment tools or treatment intervention should be considered as equal to the adverse events for your medications and reviewed thoroughly in the same context as adverse events, the overuse. Now, your patient is in the ICU, so there is a level of critical illness, varies from one patient to another. So there is a therapeutic illusion. So how to overcome the therapeutic illusion? And what's the source of these therapeutic illusions? So the healthcare provider or the critical care providers and patients are constantly looking for an exact and immediate medical answer. Patient in the ICU, so you are surrounded by your ICU, your colleagues, the nurses, the staff, the patient families, the administration. So your patient in ICU, so you'll be asked about the diagnosis, the survival, when the patient can get out of the ICU, so and why there is a prolonged length of stay, for example. So they need an immediate answer, an exact, which is sometimes difficult. And next, for source for the therapeutic illusion, that there is frequent assumption that families and the referring physician expect us to do something. I send you the patient, or I refer the patient from a secondary care facility to tertiary care facility or quaternary care facility because they don't have the service and the patient is not improving or having the same outcome. So the families or the referring centers or the referring physician beside the family, they are expecting to do something different than they did there. And also there is equate multiple tests and therapies with being thoroughly or caring because he was referred to you. And because, again, as I mentioned, because the patient is very sick, the patient needs to have something different in your management. And sometimes the reassurance, or what we call watch and wait, or wait and see, viewed with disinterest or not doing enough. Sometimes when you practice this, they are thinking you are not doing enough. But when you do arsenal of diagnostics, starting from battery of labs, battery of images, calling consultations from different services, so you did something. While just when you set in the patient scenario and revisited the data that you have it, you don't need to do too much of your arsenal of diagnoses. And also the therapeutic illusions in critical care settings can be related also to, because in the ICU you are surrounded by a multiple era of new technology and new therapies. So you have to try and you have to use it. Sometimes you are obliged to do this if it's available. And sometimes that we call it practicing the preventive medical care or conservative medical care for fear of litigation or medico-legal suing or medico-legal claim. So practice defensive medicine from concerns from the family, from the administration, from the insurance, and you are practicing what we called defensive medical care. The healthcare systems and third-party payers, like the insurance, may incentivize more testing and care than is necessary, because the patient still in the ICU, sometimes you are not reaching the diagnosis, the patient is not improving, so you have to do something. And lack of continuity may result also from the substitution of more and more excessive testing in place of thoroughly assessment. What about the decision-making in ICU? More pronounced or more clear that sometimes the decision-making in ICU is complex. Why is complex? Because there is excess information. And this excess information from the diagnostic tools that you have it will reduce the accuracy sometimes of your decision making, and yet increases the confidence in the decision making process, yes, but you have a flow of information. So you have to interpret this information in the context of decision making. The ICU is among the most information-rich environments in the healthcare, because you have a lot of data every day, every night, from the monitors, from the invasive tools, from point-of-care ultrasound, from the ventilator graphs, from the labs, from the antibiogram, a very rich environment. All information and decision-making is subject to and contributes to a cognitive bias. All of us are aware about the cognitive bias. So this information, and of course, consequently, the decision-making is subject to this cognitive bias. When the data are new, time is short, decision-making is complex, so minimizing the choices outperform the data-rich heuristic model. And this is, of course, can make your decision in critical care settings is complex. And this was really evident and clear during the COVID-19 pandemic. The excessive information, short time, and changing, very dynamic from month to another. And this was a real example for the complex decision making during the pandemic. So for less is more paradigm, in short, just because we can, does not mean we should. Yes, you can do, you can ask, you can call, but does not mean you should do it. You have to think more and more about what's the evidence behind my rationale of doing this. And this will have an impact or not on the outcome, on the cost, on the value. Okay, now moving to language of people who likes the evidence-based. I know that some of us now was hesitant about the evidence-based. The evidence-based was hesitant itself by the COVID pandemic, the COVID-19 pandemic itself. But again, now we have to go back, not away from a COVID-19 pandemic, but back to the base, back to the evidence-based. So is it the less is more paradigm supported by evidence-based? Now we are talking about ICU, not other specialties. So yes, we have interventions in the ICU for which more or doing more has no benefit or has been associated with worse outcome. On the other hand, we have certain interventions for which less has been shown to be associated with better outcome. This is the evidence that we will tell you in the next slides. Let's start with the intervention that we were witnesses over the past decade about the intervention that doing more does not have benefit or even have worse outcome. On the other hand, we have intervention of doing less have some benefit or more benefit or better outcome. So start with intervention of doing more has no benefit or associated with worse outcome. Here, the respiratory therapy, as Dr. Sarwat mentioned in the intro, for higher tidal volume. I mean by high tidal volume, 12 versus 6. And if you go back, you remember the ERDS network in the year of 2000, more than or equal to more than 20 years now, 22 years now, for the ERDS net, we are practicing the low tidal volume ventilation. So there is an evidence of doing more here is adding harm, or there is no benefit, or even it's adding harm. So for randomized control trial, when they compare higher tidal volume to lower tidal volume, or higher PEEP versus lower PEEP, or using high frequency oscillatory ventilation, it was associated with increased mortality and no benefit. And this is supported by RCTs. Regarding the hyperoxia of higher PO2, this was also has no effect or has no outcome or was associated with increased mortality, and the was supported by observational studies. Next was the fluid administration, and this is, as Dr. Sarwat said, is very area of debate in sepsis, shock patient, patient with third space lossing, patient with necrotizing pancreatitis, and so on. But again, they address the issue, and this is a very dynamic area over the last 10 years between yes or no, comparing the restrictive versus lateral approach. So initially, the lateral fluid management versus the restrictive approach or conservative approach in septic patients or even non-septic patients, they have worsening lung function, increased ventilator days and ICU stay, and sometimes they have increased mortality. And this was supported by a randomized control trial. Proceeding to blood transfusion, liberal versus restrictive in critical ill patient, medical and surgical, and also very dynamic area of research and evidence-based. And again, the address doing less is getting better outcome. So the liberal compared to the restrictive blood transfusion was associated with increased mortality. So you may add harm or you may add worse outcome. What about the blood pressure targets? From the Surviving Sepsis campaign years and years back, we are adopting target MAP equal to 65 or more millimeter mercury. So the addressed higher MAP is beneficial, like 70 or 80, and they found that the higher MAP or increasing MAP more than 65 or use of high pressure dosages has no benefit, increase mortality, increase the incidence of atrial fibrillation. And this is what's supported by also randomized control trial and observational studies. What about the steroids? So high dose steroids, especially in septic patients, 200 to 300 milligram, more than 300, and increase the duration beyond 7 days, while patient on high pressure support was associated with increased mortality. So you are adding harm or not adding benefit. For patient with acute MI, when they add a prophylactic lidocaine for prophylactic treatment to prevent VF or to reduce the incidence of ventricular fibrillation, the setting of acute MI was associated with increased mortality. So you are again adding harm. For monitoring, as I mentioned earlier, the use of Swan GANs as routine invasive monitoring adding no benefit, and this is supported by randomized control trial and was taken away now from routine monitoring in ICU. What about daily X-ray ordering? Daily X-ray in your ICU patients. Also, I will show you later, did not have on a large scale of critical ill patients, medical, surgical, when you just blindly ordering routine X-ray every day, has no benefit on the ICU care. Actually, you are adding cost and spreading infection, exposing patients, the staff for X-ray beams. What about the antibiotics? The shorter is the better, but longer duration of antibiotics has no benefit unless indicated in special cases or special indication or recommendation or special scenarios. Renal replacement therapy, high versus low volume renal replacement therapy, 35 versus 20 or 25 ml per kg per hour. So the high volume has no benefit. Moving to the sedation, continuous sedation versus daily interrupted sedation or lower sedative use with daily sedation holiday. This the daily sedation interruption was associated with better outcome, while the continuous sedation or not adopting the practice of daily sedation vacation or daily sedation holiday. If you are not adopting this and you are just continuing sedating your patients without daily interruption, this is increase the days on mechanical ventilation and the ICU stay, of course. Regarding the nutrition and the glucose control, also they address the high versus moderate caloric intake and the so-called permissive underfeeding, especially in the acute phase before the anabolic phase starts. Also, it was associated with increased mortality and adding no benefit. And regarding the glucose control, so strict versus less strict glucose control in patients with when they are predominantly fed with enteral feeding, so they have increasing the incidence of hypoglycemia and increased mortality and ICU stay. So you are adding here more strict, you are doing some harm or no benefit. So this is the evidence behind more is doing more harm or no benefit. What about the evidence behind less is more or intervention? Proved when you do less, that was translated or was associated with better outcome. So this diagram show you the regression, or you can call it between brackets the progression from 1970s to the 21st century, that when you are doing more, now we are getting less. We started with tidal volume, for example, 12 and 15. Now we are talking about 6 ml per kg. So the paradigm of less, and was supported by evidence, by randomized control trial, by guidelines, that those interventions prove to have a better outcome when you are doing less. So high PEEP, for example, did not prove to have a better outcome. Low tidal volume was associated with a better outcome. The corticosteroid use limited to 200, maximum 300 milligram per day. The hemodynamic variables, the nutritional requirements, and the permissive underfeeding. And there is a long list of our paradigm, which is less is more. You can imagine how this list is long. And as I show you in this slides, every one item of this paradigm, this is more, have its own reference, has its own evidence behind this paradigm, either RCTs or revisional study or guidelines. And wider scope: ventilatory, blood transfusion, fluids, hemodynamics, antibiotics, feeding, steroids, monitoring, vasopressors, so sedation, muscle paralysis. When every time you face your patients in the ICU, you may find a source, or you may find an item of this paradigm. If you ask me, can you choose some of those intervention, I can tell you there is a top 10 of this intervention for which more has been shown to be associated with worse outcome. As I mentioned you earlier, for mechanical ventilation, number 1, fluid management, transfusion therapy, blood pressure targeted therapy, hemodynamic monitoring, the use of IV sedation and muscle paralysis, the antibiotic use, the steroids, the glucose control, and the nutrition. Can I ask my moderators how much time is remaining for me, Dr. Tharawat and Dr. Sharif?
It's an open time, Dr. Adel. Welcome. It's an open time.
الله يخليك. الله يخليك.
ده حقيقي.
I was about to ask you, Dr. Safa, because she didn't mention a specific time raised.
No.
We are
No
enjoying
time.
it, Adel.
No time limit. No time limit. احنا قاعدين لغايه
شكراً.
المسحرات يا دكتور عادل.
الله يخليك. شكرا.
اتفضل.
So if you will ask me to be more clear and more detailed about the evidence base behind my paradigm tonight, that less is more, and supported by evidence based either RCTs or guidelines. So I told you about the top 10. So I will update you about the most of them. For example, if we will talk about the protocolized ICU care, if you remember the early goal-directed therapy versus the protocol-based standard therapy or usual care. And I think Dr. Tharwat, he presented, to my knowledge, one topic about this. صح دكتور ثروت؟
Yes. Yes, we presented
so, and I think it was very interesting, Dr. Safa. You may invite, inshallah ta'ala, Dr. Tharwat to present this. It was very nice topic from Dr. Tharwat presented earlier about the early goal-directed therapy versus the protocol-based standard therapy or usual care in sepsis and septic shock. And this is showed a no mortality benefit. And actually, the early goal-directed therapy, if you remember earlier with the Surviving Sepsis campaign, was associated with longer ICU lengths of stay and the increased days on cardiovascular support by vasopressors, and of course, increase the cost and the ICU lengths of stay. When you have protocol for sedation plus daily sedation interruption versus the standard protocol, and this is the protocolized one, was showing no mortality benefit, and actually it increased the nursing burden and workload. What about the ventilatory support? The long recruitment or recruitment maneuver and PEEP titration, or high PEEP versus low PEEP. So the low PEEP when the tackle or when the battle, and the high PEEP or long recruitment was not associated with better outcome, and sometimes was associated with increased risk of barotrauma. Regarding the resuscitation management and transfusions, of course, we are aware about the starch or colloids versus crystalloids, Ringer lactate or normal saline, and was associated the heat starch was associated with increased mortality and increased the need for renal replacement therapy and dialysis in critical care settings. I'm not talking here about the OR patients, but I'm talking about critically ill patients. So the use of heat starch or HES compared to the regular colloids or even the balanced solutions was associated with increased mortality, increased risk of kidney injury, and the need for renal replacement therapy compared to the balanced solution or the crystalloids. What about the restrictive versus liberal blood transfusion or bagged RBCs transfusion? So the restrictive approach targeting or triggering hemoglobin of 7 and above versus liberal targeting 9 or above. So they put two targets, target of 7 and target of 9. If hemoglobin above 9, they will transfuse. Sorry, below 9, they will transfuse and they will target 9. And they call it liberal. And the target for the restrictive arm, the target hemoglobin of 7 and above, and the trigger will be below 7. So restrictive versus liberal. So the restrictive shown improved survival and decrease the adverse event with this strategy compared to the liberal. So hemoglobin level of 7 in critically ill patients win the battle. What about the renal replacement therapy? So for the area of renal replacement therapy, we have timing, early versus late, and we have volume, high versus low volume. So early compared to delayed initiation of renal replacement therapy or CRRT in patients with acute kidney injury, it was not associated with better outcome, no benefit, and they avoided actually the renal replacement therapy in about 50% in the delayed arm. So early did not add a benefit. And just to mention the restrictive or back to the restrictive bagged RBCs transfusion, this was also related or linked or addressed in patients with even with acute upper GI bleeding. So if you remember in the past, they were telling us we exclude patients with upper GI bleed. Even they address this, and I will show later when they address the restrictive approach of target hemoglobin 7 and above, even in patients with acute upper GI bleeding, not life-saving bleeding, I mean. Moving to the next intervention with the evidence, targeting higher of 80 to 85 versus 60 to 70. There was no mortality benefit. there was increased atrial arrhythmias, mainly atrial fibrillation, in high-risk groups like patients with hypertension or patients with cardiomyopathy. So the higher MAP was not associated with mortality benefit when compared to the usual recommendation of MAP 65 and above. What about the nutrition? As we mentioned earlier, that early within 48 hours versus late parenteral nutrition to supplement the enteral nutrition, was no mortality benefit from using early TPN, and the late initiation, if you want to support your patient with enteral, was not using enough or receiving enough. So the late initiation was associated, late initiation of TPN, I mean, was associated with shorter ICU stay, with hospital length of stay also shorter, fewer ICU infection, and fewer days on renal replacement therapy, and of course decrease the cost. What about the energy dense versus routine enteral nutrition and mechanically ventilated patient? There was no difference on mortality when you supply with energy dense for the routine enteral nutrition prescribed for mechanically ventilated patients. And this showed also an increased the GI intolerance and the hyperglycemia, of course. What about the addressing the trophic versus full enteral feeding? Trophic, I mean, like what we call it, or on other words, permissive underfeeding versus full enteral feeding for the first 6 days of mechanical ventilation. And this is when you have full enteral feeding, especially in the mechanical ventilation patient, the first 6 days, especially the first week, we call it before starting the anabolic phase of critical illness or recovery from critical illness. When you start from the start full enteral feeding, there was no difference in mortality. There was an incidence of increased vomiting and hyperglycemia and GI intolerance as well. Okay, now if you will ask me about the protective lung strategy or light volume ventilation in ARDS patient, it's clear from ARDS net protocol type. What about the evidence in non-ARDS patient? Is it the role also for doing less in non-ARDS patient? Yes, it was addressed in almost 10 years ago, and Serpa et al. They performed a meta-analysis of 20 studies about 2,800 patients, that they showed patients who received low tidal volume had decreased lung injury development, decreased incidence of ARDS, and decreased mortality. Also, there was the IMPROVE study published in New England Journal of Medicine 2013. It was a multi-center RCT, included 400 abdominal surgery patients. They don't have ARDS, and they compared the non-protective versus protective lung strategy. And there was relative risk of 0.4 for composite of major pulmonary and extrapulmonary risk reduction of pulmonary and extrapulmonary complication, which occur in the first 7 days after surgery when they apply or they implement the protective lung ventilation. So here they addressed the benefit of doing benefit or having benefit or gaining benefit from practicing lower tidal volume ventilation or protective lung strategy in non-ARDS patients. Also, there were several studies supported the adoption of the PLV approach or protective lung ventilation approach in the settings of sepsis, trauma, multiple transfusions, and high-risk abdominal surgeries. Okay, for the ARDS, we know about the role of protective lung strategy, and for non-ARDS patient. Okay, now there is also a trend of the so-called ultra protective, below 6, even down to 4 ml Pg. So we call it ultra protective tidal volume ventilation in ARDS patient. But how low should we go? This was addressed in this study by Ritamal et al. In 2013, and the go low to 4 ml per kg tidal volume in ERDS patients, and they have a positive impact on the ventilator free days and weaning from mechanical ventilations in ERDS patients. And this was associated, yes, with the risk of permissive hypercapnia and respiratory acidosis. And this was minimized by optimizing the dead space and managing the respiratory rate. Also, addressing the higher versus lower PEEP strategies in patients with ARDS, and this was very clear that we know in this study in 2017 that the use of high PEEP or higher PEEP was unlikely to improve the clinical outcome among unselected patients with ERDS. These studied patients from 2004 up to 2016. It was around like 6 or 7 RCTs. Also, a recent study here last year, systematic review from a Cochrane database, addressing again the role of high versus low PEEP and mechanically ventilated patient with ARDS, and they found that higher level of PEEP compared to the lower may make little or no difference in the number of patients who die before discharge from the hospital. The high PEEP level did not increase the number of ventilator-free days at almost 28 days time. The high PEEP was reflected on improving the oxygenation. This is one of the positive impact of high PEEP and this systematic review. But for higher PEEP, we have negative impact on survival, on ventilator-free days, on ICU stay. This is regarding the PEEP settings or the PEEP intervention, high versus low. What about the conservative oxygen therapy? Is it best or liberal oxygen therapy? They address this in the systematic review of about 25 RCTs of oxygen in critically ill patients with sepsis, stroke, trauma, MI, cardiac arrest, or emergency surgery. And the liberal oxygen strategy, the target SpO2 of 96, and the found there is an increased mortality in those group of patients and the hospital at 30 days, also at long follow-up. This was in 2018. This is a very notable systematic review. Recently, there is a very famous study just published last year, which is the HOT ICU study, comparing or addressing the issue of lower versus high oxygen targets in hypoxemic or acute hypoxemic respiratory failure. It was a randomized controlled trial, international, multi-center, in the settings or included 35 ICUs in the Europe, in UK, Netherlands, Finland, Switzerland, Denmark, and Iceland. From 2017 to August. From 2017 to August 2020. So they address higher versus lower oxygen targets, and they concluded that targeting a lower oxygenation level of PO2 of 60 millimeter mercury did not result in lower 90-day mortality in comparison to target higher oxygen levels of 90 millimeter mercury. So targeting a conservative oxygenation target does not result in increased adverse events in contrast to the result of the previous study, which is the low CO2 study, or LO2 study. Anyway, again, this emphasized that doing less with hyperoxia or targeting lower oxygen target has I will not say better outcome, but it does not have adverse outcome. So why you are addressing higher outcome? Why you are addressing a higher level of PO2 if there is no benefit from this? While when you are addressing less, or where you adopting or accepting less, so you are not adding harm. So this is what we call it conservative oxygen therapy is the best. I will just pass quickly, and I know that you are aware about the IV fluid management in ERDS and the role of conservative fluid management or restrictive fluid management with increased lung water impact, and there is a better outcome and ventilator-free days when you keep your patients in eupholymic state while you are managing him with the ERDS protocol. Also for evidence-based, this is one of the famous studies, the FACT trial dating 2006, addressing this and the evidence behind it. But you have to remember that the restrictive strategy for blood transfusion is not only in sepsis. They address that in critical ill patient, either medical or surgical, the liberal transfusion versus restrictive transfusion, and the outcome in the critical ill patient. There was a meta-analysis published last year on the transfusion and medical hemotherapy. Last year, there was 7 trials included in this meta-analysis. They addressed the issue of liberal transfusion versus restrictive or conservative transfusion, and they addressed the outcome in critically ill patients, medical and surgical. And here, in this meta-analysis with the 7 studies, the restrictive versus liberal transfusion on the critical ill patient, the ICU mortality, the in-hospital mortality, the 20 or 30 days mortality, 60 days mortality, and longer duration also, about 90-day mortality, and they move up to 120-day mortality and ended up by 180-day mortality. And you can hear, you can find clearly that the restrictive red cell or backed RBC transfusion strategy was potentially superior to the liberal one, showing that it will be an option in our clinical practice. The restrictive backed RBC transfusion was associated with reduced in-hospital mortality in critically ill patients with anemia compared to the liberal strategy. And this was very clear from this meta-analysis. What about the transfusion strategy in patient, as I mentioned, with acute upper GI bleeding? This is dating back to 2013, almost 10 years ago, and they address the issue of restrictive versus liberal. So restrictive, the transfusion target when the hemoglobin less than 7, and the liberal strategy, the transfuse or the transfusion trigger when the hemoglobin was less than 9, and this was a randomized control trial, and they found that the restrictive strategy improved the outcome among patients with acute upper GI bleeding. The risk of further bleeding, the need for rescue therapy, the rate of complication were all significantly reduced, and the rate of survival was increased with the restrictive approach. So in patients with acute GI bleeding, a strategy of not performing transfusion until the hemoglobin falls below 7 is safe and effective. This is what they concluded 10 years ago. Last year, there was one interesting publication in the Saudi Journal of Gastroenterology. They address again, after 10 years, the restrictive versus liberal transfusion strategy in upper GI bleeding. And this is what an RCT. And here the different sources or different causes of GI bleeding, esophageal varices, malignancy, erosive gastritis or esophagitis, portal hypertensive gastropathy, peptic ulcer, and the restrictive approach, compared to the liberal approach, 7 versus 9 transfusion trigger of hemoglobin. And they found that the mortality rate of patients with upper GI bleeding in the restrictive transfusion group was similar to the liberal transfusion group. The restrictive transfusion did not increase the morbidity, did not increase the rebleeding rate, and did not increase the need for intervention when compared to the liberal transfusion strategy. And they concluded finally that the restrictive transfusion strategy is safe and effective as liberal transfusion in patients with ZBRG. The same finding back to the New England Journal of Medicine publication 10 years ago. What about the guidelines? Tell us, or the international guidelines tell us about the restrictive versus liberal blood transfusion strategy in patients with acute MI with anemia. Honestly, the international guidelines are not fully consistent about this. The European Society of Cardiology guidelines recommend to consider, now I'm talking about patient with acute MI and hemoglobin target. So the European Society of Cardiology guidelines recommend to consider the blood transfusion only in case of compromised hemodynamic status or hemoglobin less than 7. This is the European Society of Cardiology. If the patient has an acute MI with cardiogenic shock or hemoglobin less than 7. The US guideline do not recommend the blood transfusion in patients with non-STEMI with hemoglobin above 8. The British guideline recommend to consider the transfusion threshold of 8 and the hemoglobin target of 8 to 10 for patients with acute coronary syndrome. This is the British guideline. However, the American Association of Blood Bank stated clearly that, given the available evidence that we have, as I told you, is not consistent, they cannot recommend for or against a liberal or restrictive transfusion threshold in patients with acute syndrome. This is only the American Association of Blood Bank. They stand as neutral. But if you look for the European, the US, the British guidelines, the transfusion target in those patients with MI and anemia, the transfusion trigger is not consistent. And here, a famous trial published in 2020, in July 2020, which is the reality study, they addressed the restrictive versus liberal red blood transfusion strategy in patients with acute MI and anemia. This trial, they randomized 2 groups of patients, about 630 patients, into restrictive group targeting or targeting hemoglobin equal or less than 10, and to keep the target hemoglobin between 8 to 10, where the liberal to the trigger transfusion equal or less than 10, and to target the hemoglobin equal or more than 11. This is the liberal and this is the target. And they did a clinical follow-up until discharge, then 30 days clinical follow-up, and 1 year clinical follow-up. This is the reality study. They have inclusion criteria and they have exclusion criteria. One important exclusion criteria is the shock. And myocardial infarction or MI occurred after or post-MI, post PCI or post-CABG. They found that in the reality study that in patients with acute MI and anemia, the restrictive transfusion strategy, keeping the hemoglobin, between 8 to 10, compared with a liberal transfusion strategy, was non-inferior regarding the 30-day major adverse cardiovascular events outcome compared to the liberal. This is based on the reality study. Guess I will just move more quickly because for the sake of time, regarding the antibiotics in critically ill patients, again, the less is more paradigm is very applicable because all of us know that the liberal use of antibiotics has many disadvantages. Shorter duration of antibiotic treatment guided by biomarker like procalcitonin was associated with better outcome. And we went back to the motto of hit hard and short, dating back 1970s. If you will ask me about a practical bedside recommendation that minimize unnecessary antibiotic exposure in the critically ill patients. I will tell you, based on the less is more paradigm, that you want to minimize the unnecessary antibiotic exposure and the development of bacterial or microorganism resistance. So first of all, you have to collect the blood cultures or the cultures or the microbiological samples or culture before starting the antibiotics. You have to use a proven effective short course of antibiotic regimen for hospital acquired and ventilator associated pneumonia, total of 7 days. For community acquired pneumonia, 5 days, shorter duration. For acute exacerbation of chronic bronchitis, 3 days. For complicated intra-abdominal infection, 4 days. And complicated urinary tract infection, 5 days. This is based on international guidelines, mainly IDSC guidelines. Next, do not start broad-spectrum antibiotics for outdated hospital or healthcare associated pneumonia definition, and instead use what we call it multi-drug resistant risk factors from the HAP or VAP and CAP guidelines. So the healthcare associated pneumonia is outdated as a definition. We have now CAP, HAP, and VAP, and you stratify the MDRO's risk factors, and you can prescribe the broad spectrum antibiotic based on this. So not every patient in your ICU will require the broad spectrum antibiotics, especially if patient had CAP, for example. Do not administer or do not use antibiotics for ventilator-associated tracheitis or ventilator-associated events without clear evidence of pneumonia. Do not use combination antibiotic therapy for non-susceptibility or non-susceptible bacterial infection. And this is if you have the culture, you have and not use the combination therapy unless there is a certain clear indication for use of combination therapy. Also, do not rely only on the antibiotics. You have to address the source control as rapidly as possible. And this is stated clearly in the Surviving Sepsis campaign in each updated edition. Source control. Remember, for source control, 4 Ds. Device D, first D, device removal. Second D, debridement. Third D, drainage. Fourth D is definitive treatment. Next is to optimize the antibiotics regimen by optimizing the pharmacokinetics and pharmacodynamics, the PK and PD parameters. So you have to have with you the clinical pharma to optimize your antibiotic prescription and optimizing the PK and PD. Then you have to practice the proper de-escalation approach of the antibiotics when your patient is showing clinical improvement in the settings of bacterial or fungal or viral infection. For renal replacement therapy, I think it was clear that we mentioned high versus low volume of ultrafiltration, 35 to 45 versus 20, and 20 to 25 ml per kg per hour was associated with better outcome. And the extensive randomized and observational study have not confirmed and observed advantage of the high volume compared to the low volume. So why you are adding harm or you are not getting benefit if you are using the high volume compared to the low volume? Nutritional support, I think we mentioned early, the high caloric intake was associated with increased mortality, while the low caloric intake using the interroute, if indicated, that we call it permissive underfeeding, especially in the first 6 days of the critical illness, reduce the hospital mortality and the length of stay. For the biomarkers in ICU, part of your arsenal of diagnostic tools, and I think this is very important because we are relying sometimes to have an idea about the possible diagnosis or to narrow my differential diagnosis. So we are using the biomarkers. So my honest advice before ordering a biomarker testing in ICU, you have to ask yourself 4 questions. What's the pretest probability of the diagnosis we are considering here with the biomarker? Second question, are facts present interfere with the interpretation of this result, of this biomarker? Question number 3, will I change management based on the biomarker result? Number 4, will the outcome be benefited by the biomarker guided decision or not? So I will ask for these biomarkers. I think the COVID-19 pandemic was a real example for the use of biomarkers, even in outpatient basis or in hospital settings or ICU settings. And the example for those biomarkers, all of us, we are aware about the PCT or procalcitonin, the PMB, the troponin, and SUPAR. Here is a clear 4 questions that I addressed for the procalcitonin, for the PMP and troponin, and the SUPAR. For example, if you apply those biomarkers in the CAP or community acquired pneumonia, or VAB or ventricular pneumonia, or even in sepsis, you have a spectrum of biomarkers like procalcitonin, the CRP, the SUPAR, and sepsis. Additionally, you have the pro-ADM. And those biomarkers, of course, they should be interpreted in the context of the proper indications and the common pitfalls. For example, those people who rely on procalcitonin, they have sometimes inaccurate values in case of renal failure or dialysis patients or other bacterial infection or patients who are immune compromised. So patients also who rely on CRP or C-reactive protein as a biomarker, one of the pitfalls that the previous oral steroid therapy or patient with chronic hepatic failure or chronic hepatic disease, it decreased the serum concentration of CRP. So you have to be aware about this when you use for example, procalcitonin and sepsis. It should be used to guide the antimicrobial stewardship, not starting the antibiotics, but it was proven to help you for de-escalation and discontinuation and shortening the duration of antibiotics when it's used properly. This is regarding the procalcitonin, for example. Now, if we will have to mention something important about daily practice in ICU is ordering daily X-ray. I think it's very frequent in your practice that our fellows or our residents or our juniors are ordering daily labs every day, and one of the daily orders is daily X-ray. There is nothing called daily X-ray, and this was addressed in back to 2007 even. They addressed the outcome of daily X-ray and about 560 hospital admissions included about 1,780 daily routine HS X-rays. The diagnostic and therapeutic efficacy of daily routine X-ray was 4.4 and 1.9 respectively as a diagnostic and therapeutic. So we are relying on something have low sensitivity and low specificity. The total X-ray volume reduction of 35% was observed after abandoning the daily X-ray. So daily X-ray is costly and low sensitivity, low specificity, exposing patients and staff for X-ray beams. So daily routine X-ray can be safely abandoned in ICU, and abandoning the daily X-ray did not affect the clinically indicated X-ray orders, did not affect the ICU stay, did not affect the readmission rate, and did not have an impact on mortality when you abandon or you prevent or prohibit daily routine X-ray. Do it whenever it's indicated, but not on routinely based. And this was addressed clearly in mixed ICU settings. I mean by mixed, it's medical and surgical patients. Now, reaching the end of my talk tonight, which is the Choosing Wisely campaign. This Choosing Wisely campaign in critical care settings or ICU settings, it was addressed almost 10 years ago in 2012 exactly. It was addressed by the Critical Care Society collaboratives, the American Association of Critical Care Nurses, the American College of Chest Physicians, ACCP, the American Thoracic Society, ATS, and the Society of Critical Care Medicine. So those 4 societies, he did a collaborative to address the campaign in 2012, the Choose, and they call it Choosing Wisely campaign. They included multi-professional ICU team perspective, and they reflects more than 150,000 members at that time, 10 years ago. And this is the mission of the Choosing Wisely. The mission behind this, or the aim behind this, is to promote the conversations between clinician and patients by helping patients choose care that's supported by evidence, not duplicative of other tests or procedure already received, free from harm, and truly needed or truly necessary. This is the mission of Choosing Wisely campaign. And actually, I'm telling my residents, my fellows, if Dr. Tharawat, he remember who are doing the round together with the fellows or resident, I'm asking them about the last verse or ما آخر آية في سورة التكاثر. آخر آية في سورة التكاثر لو تتذكرون هي ثم لتسألن يومئذ عن النعيم. Sometimes one of هذا النعيم أو واحد من هذا النعيم هو الباتري of investigation اللي available أو offered by the hospital administration, التروبونين والسي تي سكان والام ار اي والسيري اكتيف بروتين والبروسترامينز antibiotics. When you have shortage, that when we face it really during the COVID-19 pandemic, تذكرنا كثيرا ثم لتسألون يومئذ عن النعيم. طبعا without adding harm to our patients or without jeopardizing or sacrificing the optimal patient care. There was initial 5 elements for Choosing Wisely campaign when they implemented in 2012. Number 1, do not order diagnostic test at regular interval, like every day. There is nothing called daily routine, but rather in a response to a specific clinical question. What does it mean? There is no need to order daily ECG. If your patient is young, 17 years old, female patient, coming post, for example, sepsis appendectomy, why you are ordering daily ECG if there is no arrhythmias, no ECG changes? Daily CBC for patient who has no anemia or hemoglobin drop or no blood transfusion. Daily chest X-ray if your patient does not have any respiratory problems. So this is a very important point. Second, do not transfuse red transfusion in hemodynamically stable, non-bleeding ICU patient with hemoglobin concentration greater than 7. So this apply to the restrictive approach of blood transfusion, or translated or derived from evidence based behind the restrictive versus liberal blood transfusion. Number 3, do not use the parenteral nutrition or the TPN or BBN, either peripheral or central parenteral nutrition in adequately nourished patient, or there is no contraindication to use his bowel within the first 7 days in ICU. So no, there is no role for TPN for adequately nourished patient who can use his bowel, and there is no contraindication for using his bowel. So there is nothing to use a routine TPN from the start. Number 4, do not deeply sedate your ventilated patients without a specific indication and without daily attempts to lighten the sedation, or without practicing the SPT or spontaneous awakening trial. And number 5, do not continue life support for patients with high risk of death or severely impaired functional recovery, or with futile care or palliative care, without offering the patient and their family, the care focused on the comfort care, or what we call addressing the code status or the DNR, especially when the care is futile, or we call it futile care, address the code status. Last year, the Choosing Wisely campaign updated themselves and they added another 5. So total now they are 10. So what's the next 5 adding to the previous 5? So I will just consider number 6. So do not retain or employees without a clear indication. Every day during the round, your aim is to minimize the risk of hospital-acquired infection. So you are asking about the possibility of weaning and possibility of extubation to get rid of the tube, intratracheal tube, about the Foley's catheter, is it indicated or not, and the central line indicated or not. So every day you have to ask about the device removal or indication. Number 7, do not delay the liberation from mechanical ventilation. When indicated, you are doing daily sedation vacation, no more indication for mechanical ventilation. So there is a clear indication now to liberate or to expate your patient. Please do it. Number 8, do not continue the antibiotic therapy without an evidence for need. As we told you, hit hard, then short. The shorter, the better. Do not continue the antibiotic without an evidence from the culture, from the clinical improvement, from the recommended duration. And number 9, do not delay the mobilization and rehabilitation of your ICU patient. Once the patient have or showed the stabilization improvement, get out of sedation and extubation, muscle paralysis, roids, please do not delay the mobilization, because those patients can develop significant ICU acquired weakness and muscle atrophy, prolonged ICU stay. And number 10, do not provide care if it's discordant with the patient goal or values. So you have to respect the patient will and patient wish with its dignity and autonomy, with the medical and the your hospital recommendation protocols and guidelines. Also for the ABCDF bundle, from its title, it's a bundle, all or none. Every day during the round, you have to prioritize the treatment of pain. During the round, you have to apply this bundle, ABCDEF. A, always prioritize the treatment for pain. B, take the scheduled daily SPT or spontaneous breathing trial and spontaneous awaking trial. Number C, be cognizant with the choice of drug class for sedation, about the shorter, the better, the shorter duration, the shorter half-life, with daily sedation interruption. Number D is to monitor and to minimize the occurrence of delirium. And we know, all of us aware about the consequences of delirium and the incidence of delirium in critical ill patients. Number E is to facilitate, as we mentioned earlier, for early mobilization once your patient is stable and indicated for this. Do not delay mobilization out of bed. And number F is to empower and to engage families in the care plan. And I think this in our country, it needs a cultural change when you empower and engage a family in the care plan, and it have proven to have an impact not only on the plan, even during the cardiac arrest. Let's to sum up and to finalize my talk, or the lengthy talk tonight, and I apologize for this, with these take-home messages. In the ICU, assuming that the treatment is unlikely to cause harm and is always worth trying, is an attitude that is likely to cause some harm, of course. Sometimes more is not necessarily better, and a barrage of tests and therapies should not automatically imply thoroughness and caring. remember, our goal as intensivists is supportive and let some time to allow the body to heal itself. Second goal is to minimize or to limit the harm that we cause with our diagnostic and therapeutic weapons. And intensivist role also have an impact on promoting the value in critical care by practicing less is more paradigm. You can start or you begin with one or more of the elements of choosing wisely campaign and practice. We have now 10 elements. We started with 5 in 2012. We ended in 2021 with 10 elements of choosing wisely campaign. So at least start with 1 or more, then proceed to complete the 10. Incorporate the ICU liberation A through F bundle as usual care or the standard of care for every ICU patient. And promote a learning healthcare environment in the ICU to identify and to implement evidence-based practice to the resident, to the fellows, to RTs, to the nurse staff. It's worthy pointing out that this is more paradigm is not a lazy approach. It does not mean a lazy approach and I just am and doing less and just watching. Rather, it's a well-researched, based, evidence-based and carefully thought out strategy with an aim. What's an aim? It's getting rid of therapies or intervention that does not improve the clinical outcome. And the restrictive or the judiciously restrictive approach, besides being resource efficient, could be associated with an overall mortality benefit and cost reduction. And critical care, simplicity, minimalism may be ultimate form of sophistication. Remember this, in critical care, sometimes the simplicity and the minimalism may be the ultimate form of sophistication. And I have to end by, the more action you take, the more you want to take action. Thank you. And I apologize for the lengthy talk. And I accept my apology, and I hope I delivered a message that may help us to go back to revisit our practice. And I think, inshallah ta'ala, maybe if we have another plan for next time, we may present, or someone, a volunteer, I can invite him to present the other arm, or the, now I did a pro or pros for less is more. So some people, they can do for cons when doing more is more in ICU as well. So still there is a room for doing more is more in critical ill patient. Thank you.
Very big thank you, Dr. Adel. As usual, very comprehensive and a thorough review for many stuff really in the field of critical care, and very targeted one, really impressing. As usual, I know we are running late, so I have nothing really to add. I don't have comments from myself, unless if somebody is arguing whether we can implement less is more or choose wisely in our daily practice or not, which is yes. The answer is yes, we can do it. Just change your mindset and your practice, stick to the guidelines, set your goals, set your targets, and ask yourself whether this request, this investigation is gonna change my management plan or not. We have many examples, as Dr. Adel mentioned, a lot of examples, like the escalation of antibiotics, nursing-led weaning pathway, and requesting the radiological investigations and many bloods every day, which is our mindset is routine investigations, but it is really wrong and didn't add anything for the patients rather than harm. I think I have a couple of questions here.
بليز دكتور ثروت، ممكن اقول كومنت صغير على بعد المحاضره بعد اذنك، عشان حضرتك يعني to manage the floor.
Yeah.
Just my comment, please.
Yeah, definitely. Here is a question from one of our colleagues. In light of less is more approach, what's your approach to refusing to admit a patient to ICU and decide a ward-based care, admitting a patient to ceiling of care, NIV ceiling, like level 2 care, withdrawal of treatment in ICU? Oh my God, this is really 3 different and big topics to be answered, but I will pass it over to Dr. Adel if he can comment on that.
Thank you, Dr. Sarwat. Thanks a lot. So I'm reading now in the chat. So he questioned, in the light of less is more paradigm, what's your approach to refusing to admit patient to the ICU and to decide a ward-based care? I do not understand who is refusing. You mean the patient or the family refusing to admit?
I think he means ourselves as the physicians.
Refusing to admit?
Yeah, critical care doctor refuses to admit the patient, if this is my understanding.
Okay, the second point, admiring a patient
with not admitting, this is just typo.
Admitting patient with a ceilings of care, NIV. Okay, so and number 3, withdrawal of treatment in ICU. As Dr. Sarwat mentioned, and I think he answered this, is I think this is away from my talk tonight. But number 3 is withdrawal of treatment in ICU is directly related to number 5 in Choosing Wisely campaign. If you remember that, to offer the withdrawal of care or sometimes withholding the therapy according or based on your local protocol and DNR policy, or withholding policy, or withdrawing the policy. So for example, in my hospital, we have DNR policy and we have withholding therapy policy, and we have withdrawal therapy policy. Also in the Western countries, they have this. I am aware that in Egypt, for example, we are not adopting frequently the DNR policy. Sometimes they call it social DNR or among our staff. But again, whenever indicated, this should be addressed daily. The code status, when the care is futile or the patient will not benefit from advanced intervention or advanced ICU care. And it depends again, do you have a supported DNR policy or withdrawal policy or withholding therapy in ICU settings whenever indicated, and you have inclusion criteria. Refusing, still I do not understand who refused to admit patients to the ICU at the site for ward-based case. Again, it depends. If the patient again is indicated to ICU according to admission and discharge criteria and policy, patient filling his full code, he is not a DNR, not a palliative care, not a futile care, I will address the admission with his MRP or the main responsible physician either in the ER, or his responsible physician with his family, with the patient, if he's competent enough to give the decision, and I will explain to him. But if he's refusing, I have to explain the consequences, and should be documented to protect yourself and to provide the optimal care, because at the end, who will decide to take care of critically ill patients in a ward case management? Admitting a patient with ceiling of care in IV, I think this is, we did it a lot when we have bed crisis, we have shortage of ICU beds, we have seen this frequently, and during the COVID-19 pandemic, that we manage patients on NIV in the floor until we provide a bed. But at this settings, I have to have a dedicated team like the rapid response team or critical care response team with nursing ratio 1 to 2 or 1 to 3 at least.
Yeah, that's very sensible. Really, it is a big dilemma with many ethical and medical legal issues around. So from Dr. Safa, an amazing lecture. Thank you. Muhammad, I think ethical, social, and legal consideration might vary between different countries in case of withdrawal. Yes, you are right. Thank you, Muhammad, for the comment. Interesting lecture. Thank you. Very useful lecture. Thank you. And I think there is no more questions, Dr. Adel. Thanks.
I have a comment, Dr. Sarwat. I have a comment, please.
Just there are a few papers talking about benefits of daily focus in ICU clinical rounds. Dr. Adel, this is another question here.
Sarwat, the question back, sorry, again.
There is
few papers talking about benefit of daily point of care and clinical focus and clinical. Very interesting question. Yes, the evidence now over the past 2 years now with the advance and the getting experience with POCUS and the proven role of the POCUS in ICU setting being less invasive, reproducible, bedside, and the data that you have it hemodynamic wise, managing crashing patients, even for the airway, helping you during even the tracheostomy, line insertion. I think this is one of the standard care applying now the point of care ultrasound, its role of undifferentiated shock. And I know some hospitals they have a POCUS round beside the clinical round. They have POCUS round because people there are experienced enough. Even the fellows, the resident, once they finish the endorsement, they do the quick POCUS, like 10 to 20 minutes screening before starting the clinical round. Then they will add the data to his finding and notes. Then he will start with presentation. For papers, yes, we can provide, if you are asking about certain papers about the role of, or articles about the role of daily POCUS in ICU round. Yes, we can provide.
Thank you, Dr. Adel. Dr. Safa?
Yes. Really, it was the most informative, from the most knowledgeable and experienced, delivered by one of the most talented and gifted lecturer. So we gain more and more, reaching the most. So really, we haven't any less at all with our great Prof. Dr. Adel Ahmed Hussein. Many thanks, Dr. Adel. This is my comment.
Dr. Safa. Thanks a lot.
We have the most from everything.
Thanks a lot. I am really delighted, and I'm really appreciating for your invitation tonight, with being with you, with our colleagues, with our moderators tonight. I'm really happy and glad, really. And as I mentioned earlier, in my dictionary, nothing can express my feelings tonight. And I hope, inshallah, to be repeated more and more. جزاكم الله خير، واسال الله تبارك وتعالى ان ينفع بكم جميعا، وان يجعل ما قد الليله يعني في موازين الحسنات. وبعتذر لكم جميعا عن الاطاله، يعني سامحوني، وبعتذر مره ثانيه.
خالص، بالعكس ان شاء الله كل ثانيه في ميزان حسنات حضرتك يا دكتور عادل. انا متشكره جدا جدا جدا، ربنا ينفع بحضرتك دايما يا رب. واكيد السمعه الجميله اللي سابقه والسيره الطيبه اللي سابقه حضرتك كان كل الناس عندها حق فيها. يعني انا اقسم على ذلك الان يعني. لا فعلا.
وتحياتي لكل الزملاء في المنوفيه وجامعه المنوفيه وفي الكلاب، واسال الله تبارك وتعالى ان ينفع بهم ويزيدهم علما ويبارك في علم حضرتك وفي علم الزملاء المودريتورز اليوم. ربنا يجزيهم كل خير.
ربنا يكرمك.
واشكر كل احد كلف نفسه بالحضور، ويعني وكلف نفسه واستحملني في الساعه ونص اللي فاتت دي.
لا
او سأل او كتب شات او شكر. جزاكم الله كل خير.
Very nice time. We are glad and pleasure for you.
Dr. Adel, thank you very much.
Thank you.
Dr. Sharif.
Thank you very much, Dr. Adel. Very informative lecture, addressed a lot of topics with a lot of decisions. sure will be helpful in the management of our patients. But I have a question. What's your recommendation in starting to implement this concept, less is more, in our ICUs? The steps of implementation, from where should we start?
Thanks, Dr. Sharif. Jazakallah khair. Thanks a lot for your appreciation and for your being a moderator tonight with me. And your question is very practical, and I was waiting for this question. And as I mentioned in my slides, this is the answer of your question is, how can we implement this regarding the less is more paradigm? Is it applicable for implementation? Of course, yes. In my opinion, yes. Especially in the what they call it middle and low income countries. As you know, they classify countries according to the hospital resources. But again, COVID-19 pandemic explored that no one can or no one is immune from this crisis or this disaster. So we have to think about, again, less is more to save costs, to improve the outcome, especially for the items that proven to have better outcome and did not add harm, or the intervention that we are doing more and we are not getting a benefit. So to answer you is regarding from where we can start, I can start from the Choosing Wisely campaign. As I mentioned, you can choose one or two from the Choosing Wisely campaign. Those are 10 items. You can start one, then you can go gradually. So as I show you in this slide, here is the answer. When you want to promote the less is more, or to promote the value by implementing less is more paradigm, you can start from the end, from the Choosing Wisely campaign. You can set with your administration, with your staff, and you collaborate with the nursing, with the RTs, with the clinical dietitian, with the clinical pharmacist, with the infection control, with the ID people, and you choose. You can present the 10 items. You can start with one or two of those elements of the Choosing Wise. Then you proceed until you implement the 10 based on your local practice and the local policies and protocols. Second, to use the bundle, as we mentioned, the ABCDEF bundle. Unbundle, it means hizma, all or none. You have to apply from A to E, again, based on your local protocols and policies. Number 3 is to promote a healthy learning environment, starting from the resident level, fellowship level, nursing staff, RT, and collaborative multidisciplinary settings. So all people at multiple levels will speak the same language. Less is more, or choosing wisely.
Yeah. Anything else?
شكرا جزيلا دكتور عادل. شكرا جزيلا يا فندم. محمد طريح معاك.
الله يخليك دكتور شريف.
يا باشا نورتنا ونورت الجروب. شكرا جزيلا، شكرا جزيلا.
الله يخليك، تحت امرك. شكرا جزيلا، وشكرا لكل الزملاء اللي كتبوا اعجابهم بالمحاضره وبالوقت. جزاكم الله كل خير. انا اللي بشكركم ان حضراتكم استحملتوا كل الوقت ده وانصتوا وجلستوا قرابه ال90 دقيقه يعني تستمعوا، فجزاكم الله كل خير، وشاكر ومقدر وكل الابريشيشن على راسي من فوق.
السلام عليكم.
عليكم السلام.
عليكم السلام ورحمه الله وبركاته.
عليكم السلام.
وسام سلطان. وسام تفضل.
If you let me, I have a comment. Thank you, Dr. Adel, for your marvelous presentation. It was very amazing. You have gathered a lot of evidence-based data. We are facing every day in our practice in ICU. And if you are proved that this data is evidence-based, like tonight, we have a long presentation and is associated with long, high evidence-based knowledge and benefits. Thank you too much for your presentation today. My comment that as we are intensivists or we are dealing with the critically ill patients, we are looking for the targeted medicine or goal-directed therapy. As sometimes less is more, and another times more is more. That's in our practice we are facing every day. So evidence-based medicine, looking for the targeted medicine or goal-directed therapy, if you agree with me. Thank you, Dr. Adel, very much for your fascinating lectures.
السلام عليكم ورحمة الله وبركاته. شكرا جزيلا دكتور وسام. جزاك الله خير, and thanks for your comment and for your abbreviation. Sorry for your appreciation. I'm really thankful. جزاك الله كل خير. I totally agree with you that as I am now supporting the motto or the paradigm of less is more, but again, as you mentioned, sometimes also more is more, or goal-directed therapy is really supported and really wanted. For example, if I'm talking about mobilization or physiotherapy, here is an example of doing more and more. And my target here is to get the patient out of ICU as early as possible, to lengthen the ICU stay and the cost, to minimize or to prevent the risk of ICU acquired weakness and ICU acquired infections. And of course, I will reduce the cost. And this is one of major KPIs and goal-directed therapy for our ICU and the hospital and the administration. And for the patient also standard of care, either on private basis or insured covered patient. So totally agree with you. So as I mentioned, again, on the other arm, there is still and there is a dynamic rule again for more is more. So sometimes, yes, it's not the base is less is more, but here I address, as you mentioned, with the evidence-based for the intervention that till today we are practicing every day. Like I mentioned, the daily routine X-ray. And I will not say I'm sure, but I'm very confident that when you visit most of the ICUs, national or international, you will just explore the next morning orders for your patient. You will find unwanted labs or unwanted images like the routine X-ray, and your patient does not need it, or daily blood gas or daily CBC. And of course, we know that one of the common sources of ICU acquired anemia is the frequent sampling. Like every day, your patient is losing like between 20 to 30 ml just for labs, beside the lines, beside the bleeding, the drains. So I totally agree with you. And as I promised, if we have time, inshallah ta'ala, we can just to maximize the benefit, was to present the other arm or the cons بقى, بما ان احنا قدمنا البروز اللي هو more is more.
Inshallah. Thank you, Dr. Adel, and jazakumullah khairan.
Thank you, Dr. Adel, and thank you, Dr. Wissam. And just
thank
to
you
add,
very much, Dr.
the patient is, the ICU patient is really a dynamic patient and changeable every day. So you have to be vigilant to your patient in individual basis, not necessarily to be less is more in every patient. You have to be vigilant that this patient is different in his response to comorbidities, and ongoing pathology is much different than the others. And you have to like individualize your practice to the patient But as much as you can, as Dr. Adel mentioned, like the routine investigations, routine bloods, routine gases, routine X-rays, is sometimes it's unnecessary at all, and it's not cost effective and time consuming, and more harmful than beneficial to the patient.
Thank you, our dear professor. Thank you, Dr. Adel. Thank you, Dr. Safa.
Thank you. I think we came to the end here, Dr. Safa.
Yes. أنا طولت عليكم طبعا.
لا بالعكس.
دكتورة تحت أمرك.
بالعكس، تحت أمرك.
دكتور عادل بروميس مي واحنا على الهواء مباشرة كده ان احنا لنا لقاء تاني في اغسطس او في سبتمبر، يبقى كتر خير حضرتك. ان شاء الله باذن الله.
حضرتك تأمرينا دكتورة.
شكرا لحضرتك. دكتور ثروت على الهواء مباشرة ان شاء الله، حضرتك هتديني ميعاد في سبتمبر ان شاء الله باذن الله.
ان شاء الله.
هو في بس مؤتمر اسكندريه هيبقى في حاجه و20 سبتمبر، فحضرتك يعني بعد اذنك لو في اول سبتمبر هتبقى حاجه جميله جدا جدا، وهيبقى رائع لو حضرتك الجمعه والدكتور عادل الجمعه اللي وراها على طول، هيبقى العيد بتاعنا ان شاء الله.
ربنا يكرمك ان شاء الله، نرتب ان شاء الله.
ان شاء الله مع حضرتك بقى ان شاء الله باذن الله.
ان شاء الله ربنا ييسر.
شكرا جدا يعني امسيه سعيده علينا كلنا، يعني كانت نسائمها كلها علم وحيويه ونشاط، وكل الناس قاعده يعني رابطه الاحزمه ويعني مبسوطه، ويعني شكرا لحضرتك دكتور عادل، متشكره جدا. شكرا لحضور حضرتك، متشكره جدا لحضرتك دكتور ثروت، متشكره جدا شريف موافي، متشكره جدا وسام سلطان وكل الاتندي، دكتور ياسر طبل ودكتور سمير الكفراوي وكل اساتذتنا المحترمين اللي حضروا معانا وشجعونا. شكرا جزيلا لحضراتكم جميعا. شكرا وامسيه سعيده علينا كلنا. شكرا جزيلا.
نستودعكم الله دينكم وامانه خاتم الاعمال. شكرا.
نستودعكم الله الذي لا تضيع ودائعه. في رعايه الله. مع السلامه. مع السلامه.
جزاكم الله خيرا جميعا. عليكم السلام ورحمه الله.
عليكم السلام ورحمه الله وبركاته. عليكم السلام ورحمه الله وبركاته. عليكم السلام ورحمه الله وبركاته. كتاب والله كتاب.